morning to everyone joining us from different parts of the world. My name is Assistant Professor Dammeka, and I am joining you today from University of Gondar, Ethiopia, and serving as Director of Education and Training of the TORG Global Education and Training Committee. On behalf of the Operating Room Global and the TORG Global Education and Training Committee, I am delighted to welcome you to today's global webinar, which is the first of the 2026 actually. So we are pleased to have you through multidisciplinary audience with us today, including surgeons, anesthesia providers, nurses, surgical technologists, perfusionists, educators, researchers, students, and other health professionals. So we are currently joined by participants from multiple countries across different time zones, and we sincerely appreciate your time and commitment to continuous learning. Whether you are joining us from Africa, Europe, Asia, and the Middle East, the America, or elsewhere, you are very welcome to this webinar. Good morning to those joining early in the day, and good afternoon those in the middle of your day, and good evening to those of you joining us later. We are grateful to have you in this webinar. We strongly encourage active participation throughout the session, and please use the chat box to introduce yourself by sharing your name, professional title, and country. And you can post your question and comments at any time during the presentation. Our moderation time will be actively monitored the chat and will bring your question forward during the discussion segment. For those joining TORG session for the first time, the Operating Room Global is a multidisciplinary professional platform representing over 260,000 surgical and perioperative professionals across more than 110 countries in the world, making it the largest global network of operating room professionals worldwide. TORG brings together more than 42 healthcare disciplines and specialties currently, and operates as a non-profitable organization founded in Nigeria in August 2015. Today, TORG has over 20 active chapters globally, including representation across more than 31 African countries. Our mission is just to advance surgical and perioperative care through education, research, advocacy, innovation, and capacity building, with a strong focus on safety, equity, and system strengthening. TORG is an internationally accredited continuous professional development provider, or it is a CPD provider, recognized by the CPD groups, underscoring the quality and global relevancy of our education activities, and is supported by its academic and innovative arms. The Operating Room Global Center for Education, Research and Innovation incorporates in Ireland, which leads our global agenda in education, research, innovation, and partnerships. Our affiliation joined the Operating Room Global is an open access peer-reviewed international journal inaugurated in May 2025, providing a platform for high-quality evidence that informs practice and policy worldwide. TORG is also proud to host its own Institutional Review Board, or IRB, officially registered with the U.S. Office for Human Research Protection, reinforcing our commitment to ethical, responsible, and globally credible research. TORG is driven by a voluntary leadership model powered by passionate professionals who contribute their time, expertise, and vision to strengthen global surgical care. We are actively engaged with global alliances, including the G4 Alliance, Intersurgeons, and are listed with the Union of International Association and the Global Civil Society databases, reflecting our global accountability and reach. So this is the 2026 first webinar. And once again, welcome to our webinar. And this is by now the floor is officially opened for everyone. And thank you very much for your patience and active listening. Thank you. Back to you, Farhat.
Thank you so much. Hello, everyone, and welcome. We're so happy to have you here today, and it's especially meaningful since this is the first session of the Global Education and Training Committee. My name is Farhat Zikri, and I serve as the Secretary for Performance, Coordination, and Reporting with the Global Education and Training Committee here with TORG. It's my pleasure to welcome and to introduce today's guest speaker, who is also a member of the Global Education and Training Committee here with us, Dr. Bhavneet Bhalla. Professor Bhalla is a consultant laparoscopic, bariatric, and robotic surgeon, as well as a gastrointestinal endoscopist. He is the director of the World Laparoscopy Hospital and serves as associate editor of the World Journal of Laparoscopic Surgery. He is a member of the Global Education and Training Committee of the Operating Room Global, the chief coordinator of TUGSS Endoscopy, and a member of the Education Committee of the Robotic Global Surgical Society, TORGSS. Professor Bhalla brings extensive international experience in minimally invasive surgery education, surgical training, and capacity building, with a strong focus on foundational principles, patient safety, and competency development in minimally invasive surgery practice. We're delighted to have him with us today to speak on principles and foundations of minimally invasive surgery. Please join me in welcoming Professor Dr. Bhavneet Bhalla. Professor Bhalla, the microphone is yours now.
Thank you, Farhat. Thank you for that kind introduction. And it's my pleasure to be a part of these the Operating Room Global's academic activities. And it's a pleasure to be actually the first speaker of the first session of this new year's. So I'd like to share my screen now and just confirm to me whether my audio and video are clear and I can see my screen. Is my screen
Yes,
visible to you?
Professor Bhalla, it is perfectly
Sure.
visible. We can hear you.
So, very good morning, good evening, or good afternoon to all the attendees, depending upon which part of the world you are joining us today. It's a pleasure to be a part of this academic session, and I'm happy to talk to you about the principles and foundations of minimally invasive surgery. So, I believe this is a very, very relevant topic for all the surgeons who are doing laparoscopic surgery, and not only the surgeons who are operating, but also the entire OT staff and the rest of the team who is involved in one way or the other with this kind of surgical procedures. So, I have divided my talk into these learning objectives, and over the next 30 to 40 minutes, I'm going to talk about the evolution and the rationale behind minimal access surgery. What are the core fundamental principles of this surgical approach, and the various safety aspects which we are all always watching out for, and what are the future possibilities of this way of doing surgery. So, what do we mean by minimally invasive surgery? It basically, in the simplest of the words, this refers to the surgery which is being done through small incisions using some specialized instruments. And it is known by many different names. It is also referred to as a keyhole surgery or a buttonhole surgery. Well, these are not recognized medical terminologies or names for this approach to surgery. These terms are usually used when we are trying to explain to the patient and tell him or her how we are going to operate using a very, very small incisions would somehow resemble the buttonholes or keyholes, which the patient will see later on. These are not medical terms. Medical term would be a laparoscopic surgery. However, laparoscopic surgery basically refers to the procedures which we are going to do intra-abdominally. But as we all are aware, minimal access or minimal invasive surgery is not only limited to the abdominal procedures. We are doing axilloscopies, we are doing preperitonioscopies, retroscopies, we are doing axilloscopies. So laparoscopic surgery is not a true and complete representative of what I'm trying to talk about. Another name for minimally invasive surgery is actually minimal access surgery. And to my mind, this is the best name for the kind of procedures which we are talking about. Our access to the space or the cavity which we are going to operate is limited. It is minimal. We are going to access that space through a very, very small incision. It could be abdominal, it could be extra abdominal, or any other part or organ of the body. So, to my mind, the best name, if we have to select one for these procedures, would be a minimal access surgery. Now, depending upon the, excuse me, my slide is not moving. Yeah, excuse me. So, depending upon which organ or which space we are trying to operate. Now, we could be operating inside the abdomen, we could be operating inside the thoracic cavity, we could be inside some organs like the bladder or the uterus, we could be operating within a joint, or we could be simply doing a retroperitoneoscopy. So, as we can see here, the surgery, the procedure takes the name of the organ or the cavity in which we are going to operate. And thus it becomes a laparoscopy or thoracoscopy or a hysteroscopy or a cystoscopy and so on and so forth. This name laparoscope was actually coined by Professor Hopkins. He is the same gentleman who invented these rod lens systems in 1953. And without having these rod lens systems, a laparoscope would not exist and would probably not be doing laparoscopic procedures. So a huge credit for the current kind of procedures which you're doing goes to Professor Harold Hopkins. Now, a little bit about the historical trivia and how the minimal access surgery originated and how the progress has been over the last century or so. So, although the actual laparoscope was available to us in 1953 only, but much before that, many people attempted to develop certain gadgets which would allow us to look inside the abdominal cavity. So, von Otto, way back in 1901, he actually put together the speculums which are available, and he used to introduce that speculum inside the abdominal cavity and try to have a look inside the cavity using a candle light. This apparatus was known as a Licht lighter, and this is recognized and documented in the history as the first documented case, and they called it a cilioscopy, which is coelomic cavity is another name for the abdominal or the laparoscopic cavity. After that, in the era of modern laparoscopic or minimal access surgery, the first documented laparoscopic appendicectomy was done in 1983 by 𝐻𝐸𝐵. So interestingly, 𝐻𝐸𝐵 was a gynecologist by training, and the credit of doing a first minimal access general surgical procedure, the lap appendectomy, goes to a gynecologist. A couple of years after that, in 1985, Eric Muhe did the world's first lap cholecystectomy. So 1990s and 1980s is considered as a golden period of laparoscopy or minimal access surgery. People were trying out new things, they were discovering different surgeries, and they were coming up with newer and newer procedures which could be done laparoscopy rather than open surgery. So 𝐲𝐸𝐽 did the first laparoscopic hernia repair in 1987, followed by Reach, who did the first laparoscopic hysterectomy in 1988. Over the years, the specialty has diversified. Now, minimal access surgery is not only limited to laparoscopic surgery. With the introduction of the robotic systems, we are routinely doing robotic minimal access surgery. The credit for this first robotic lap surgery goes to Dan Stanovici in 1993. 𝐸𝐳 did the first colorectal laparoscopic surgery, and then the first notes procedure, again a method of doing minimal access surgery. So the first notes were done in Strasbourg in year 2001. Laparoscopic surgery or minimal access surgery has now evolved into many different forms, which I'm going to talk about a bit later in my presentation. Uh, the current status is this: there is a universal adoption of this way of doing surgery. No surgical specialty has been left untouched as far as this technique or method of doing surgeries is concerned. It could either be general surgery, it could be urology, it could be orthopedic procedures, thoracoscopic procedures, endocrine surgeries, neurosurgeries. You name a surgical specialty, and you will find that the surgeons now are doing the procedures via minimal access approach. So, why all of a sudden minimal access surgery or this approach became so universally accepted? Well, the reasons are obvious. We are going to operate through very small incisions, and this leads to a drastically reduced post-operative discomfort of pain. Compared to an open surgical procedure, the requirement of post-operative analgesia is one-tenth probably. There is less chances of wound complications. So the patient recovers fast and stays in a hospital for a much shorter time. And obviously, smaller incisions are going to give you better cosmetic outcomes also. These are the benefits which minimal access surgery offers to the patients directly. Indirectly, it also affects our healthcare systems. Because of the shorter stay of the patients in the hospitals, there is a rapid turnover of the hospital beds. So the same infrastructure can now cater to a higher number of patients. The patients themselves return earlier to work. They are recovering faster and then they get back to their normal day-to-day life much earlier. And this contributes loss of man hours to their jobs, which are earlier being lost because of prolonged hospital stays. In the long run, all this is cost effective. With the advent of minimal access surgeries, we are not only treating our patients in a better modality, we are actually saving millions and billions of dollars for that. So, what are the core principles of minimal access surgery which every OT staff, especially the surgeons, should be aware of and should be practicing and following? So these are the various core principles of minimal access surgery, and I'm going to start by talking a little bit about the ergonomics of this kind of surgery. So the first principle is we must follow ergonomic efficiency. Now, what I mean by this is ergonomics is the science of designing and arranging the equipments or machines in such a way that the people and the machine they interact in a more efficient and a safe manner. So it is basically about understanding the man and the machine interface. And if you look at laparoscopic surgery, it is entirely dependent on machines and equipments. Your laparoscopy system includes a complete endovision system. You include an energy source device there. You have a suction machine there. You have a light source there. And you have an insufflator there. And then you are going to operate using different hand and operating instruments. So laparoscopic surgery is entirely equipment dependent. And that is why ergonomics is one of the first important core concepts which any laparoscopic surgeon should understand. Unfortunately, there is a big lack in this awareness. And this lack of knowledge of ergonomics leads to a lot of struggle during the surgery. It can prolong the operating time of the surgeon. It can cause more fatigue, more physical wear and tear to the surgeon. It ultimately affects the efficiency of the surgeon, and this indirectly may increase the risk of complications happening during the procedures. So, in a large survey of more than 5,000 surgeons, it was found that 70% of the surgeons reported some sort of pain or muscle strain because of the surgeries. Now, this could be involving your back, your neck, your upper body, your arms, your shoulder. And surprisingly, only 29 to 30% of this took it seriously and saw what was wrong and how to improve this. That means majority of the surgeons are still lacking that awareness of the ergonomic concepts of minimal access surgery. So I'm going to quickly mention a few of the very, very important ergonomic principles. The moment you start talking about laparoscopic surgery and you enter into the OT, you must make sure that you are following these principles. The first principle is that of coaxial alignment. And what I mean by that is when the surgeon is standing and operating upon a patient, then the eye of the surgeon, the target area where the surgeon is going to operate, and the monitor on which the surgeon is going to see while operating, all the three must be in the same axis, in the same straight line. This is known as the principle of coaxial alignment, and we follow it in real life. If you're driving a car, where do you sit in that car while you're driving it? You are sitting right behind the steering wheel, isn't it? And you're looking directly at the road. When you're watching a TV, where are you sitting? You are sitting right in front of the TV screen. We follow these coaxial alignments. It comes naturally to us, and we must remember to use these principles when we are operating also. So whether you are doing a lap chole, lap appendix, hernia, a TLH, any laparoscopic surgery, always follow this coaxial alignment. So in some surgeries, like some pelvic gynecological procedures, we can have a little bit of liberty, and the monitor, if it is not right in front of the surgeon, could be placed at least or maximum of 10 to 15 degrees either to the left or the right. It is okay, and we can still manage to do the surgery ergonomically, because here I'm talking about pelvic procedures, and the organs like the uterus, the tubes, the ovaries can be manipulated, and hence it doesn't affect much if you're not following the coaxial alignment to the T. The next important principle is make sure that you are placing this monitor on which you're going to see at the ideal distance. So what is the ideal distance to place the monitor? How far that monitor should be away from the surgeon? Well, there is a very simple formula for that. Find out the size of the monitor. Now, supposing you have a 12-inch monitor, simply multiply that 12 inches by 5. So the distance between the monitor and the surgeon should be 5 times the size of the monitor. This is very important because at this distance, you will get the maximum resolution of the eye over the macula in the retina of your eye. So you will see the sharpest image on the screen if you as a surgeon are going to stand at a distance which is equal to 5 times the size of the monitor which you are going to operate upon. Something very simple but very important is the correct height of the OT table. So the height of the OT table should be such that when you're operating as a surgeon, your hands should be at your elbow level and your arms should be by your side. The arms should be adducted. Any other position except this is going to increase your strain. It is going to cause more wear and tear on your body. So how do you find the ideal height of the OT table? Roughly, it is about half the height of the surgeon. So if you are 5 feet tall, the OT table should be 2.5 feet tall. This is a basic thumb rule, very simple. And if it is higher than that, what will happen? You can see in this image here, the moment the height of the table goes above your waist level, you will have to lift your hands above the elbow level. So you are going to operate in a very awkward position and your arms will also be abducted. This brings down the efficiency of the surgeon. Any abduction of the arms of the surgeon beyond 15 degrees will cause more and more fatigue, decrease the efficiency of your surgeon, and also increase the chances of complications. So simple principles which are easy to implement, but we need to remember and start practicing them. The second important concept of minimal access surgery is to have triangulation. Now, what I mean by this is that you need to create a working angle or a triangle between your left hand and the right hand instruments. Again, giving you an example of day-to-day life. Now, whether you are eating with a knife or a fork, whether you are knitting, or whether you are writing or using your laptop and typing with the keyboard, you will find in all these examples, the angle between your hands or your instruments which you are going to hold in your hands is automatically around 60 degrees. This is the ideal angle which you should have. Same concept we are going to apply in minimal access surgery also. Why? Because it increases our precision of work. It gives you a better depth perception, something which I'm going to explain in a minute, and it will cause less fatigue and wear and tear to the surgeon. So this angle which is found between your left hand and the right hand instrument is known as the manipulation angle. So it is the angle between your two operating hands or operating instruments. Ideally, during laparoscopy, this angle, which we call as the manipulation angle, should be 60 degrees. Okay. So as it increases beyond 60 degrees, it will lead to, and you can see from this image, if the instruments are further away, the angle increases, and the further apart the two ports or the instruments keep on going, the manipulation angle keeps on increasing. But at the same time, your arms would also be getting more and more abducted. And we all understand this will increase your operative fatigue. What happens if the manipulation angle is less than 60 degrees? Well, now your two instruments will start clashing outside when you are going to operate. And this, how do you decide the manipulation angle of 60 degree? This actually depends on your port position. So where are you going to put your ports? Because the instruments are going to go through these ports. So once you have put your ports, the manipulation angle will be fixed now. So the point here to understand is, it is more important to get your port positions right. Something which I'm going to explain to you in a minute. So along with this manipulation angle, there is another working angle which is very important for us, and this is known as the elevation angle. Elevation angle means the angle between the instrument and the abdominal wall. So ideally, this elevation angle should be around 30 degrees. This is the ideal angle to have your instruments when you're going to do dissections and suturings and knotting anywhere. Again, this elevation angle will depend upon the port position in laparoscopic surgery. In open surgeries, you can keep on changing your elevation angles, isn't it? You are free to move your hands. You can free to move your hands up and down and operate in whatever angle you want. But in laparoscopic surgery, the instrument is going to go through a cannula, which itself is passing through the abdominal wall. So the moment the instrument goes in, you will have a particular elevation angle. So third angle, which is relevant to all laparoscopic surgeons, is what we call as the azimuth angle. This is the angle between the telescope and your hand instrument. So in this image, if you have a look, right in between your left and the right hand instruments, there is a laparoscope or a telescope. Azimuth angle is the angle between any of your instrument and the telescope. So you will have a azimuth angle on the left side and azimuth angle on the right side. Ideally, this angle should be again 30 degrees on each side. So azimuth angle can be adjusted to maintain a manipulation angle of 60 degrees. So what was the manipulation angle? If you remember from the previous slide, it was the angle between your left and right hand instruments. And azimuth angle is the angle between your one instrument and the telescope. So to have an ideal azimuth angle of 30 degrees, you must put the working ports for the instruments 7.5 centimeters on either side of your telescope. This is very important to understand. The moment you have your instruments 7.5 centimeters on either side of the telescope, and I am basically talking about a average size adult patient on which you are going to operate using the standard length of laparoscopic instruments. So for an average adult size patient, the length of the laparoscopic instrument which you are going to use is 36 centimeters. Laparoscopic operating instruments are available in 4 standard lengths. So they come in lengths of 20 centimeter and 28 centimeter, and these you are going to use for your very, very small and slightly bigger pediatric patients. In an average size adult, the instrument length is 36 centimeters. Okay, so using a 36 centimeter long instrument, if you put your working ports 7.5 centimeters on either side of the telescope, automatically your azimuth angle would become 30 degrees and the two azimuth angles come together to give you the manipulation angle, which automatically will become 60 degrees. Do remember, do not keep increasing the azimuth angle beyond a certain time. So there is a range of 15 to 45 degrees. But as you keep on increasing the azimuth angle more and more and more, mirroring would happen and you will find it very difficult to operate. Mirroring happens when the visual axis and the action axis of your instrument are exactly opposite to each other. This is just a summary of the various angles, the working angles and the triangulation, which is very important in laparoscopic surgery. So here you can see this is the telescope right in the middle. The angle between this hand instrument and the telescope is the azimuth angle of 30 degrees. Similarly, the azimuth on the opposite side also will be 30, so that you get the manipulation angle of 60 degrees here. Third important principle is optimal port position. I just mentioned a while ago that these working angles actually depend upon the port placement. So very important to understand and put the ports in the correct position. Wrong positioning of the ports is one of the most common causes of a stressful laparoscopic surgery. The surgeon keeps on struggling if the port position is not ideal. So where to put the camera port and the working ports? So the first port which you are actually going to put when you start your surgery is your camera port. Plan your ports wisely. This is the first decision which you have to make during that surgery, and this is the most important step of the surgery. Wrong ports, you will keep on struggling throughout the surgery because of poor ergonomics. So optimal port position is going to ensure that you have the ideal working angles, the manipulation angle is correct, the azimuth angle is correct. Your own hand remains in a neutral position, adducted by the side of your body. And there is less clashing of the instruments happening either inside the abdomen or outside. So various factors which have a bearing on your decision of port placement. Look at the overall body habitus of the patient. Is there a history of some previous surgical procedures being done on the patient? So let me talk about the ideal position for the camera port. In laparoscopy, umbilicus is a very favored spot for all laparoscopic surgeons. It is considered the best site for putting the optical or the camera port. And there are reasons why we do this. This is basically because the umbilicus is more or less located in the central position of the abdomen. So if your telescope or the camera is going through the central part of the abdominal wall, it allows you easy access to all the quadrants. From there, you can operate in the upper abdominal, you can operate in the pelvic cavity, you can operate on the parietes also. And because the telescope is also going to be at the highest point, so once you're going to create the pneumoperitoneum and umbilicus being the central part of the abdominal wall, it will be at the highest point also. It causes less swatting of the telescope with the instruments. Ergonomics are very good. Additionally, since you're going to go through that umbilical scar, there are less chances of a port site hernia forming here. And obviously, that scar or the incision which you're going to give will be hidden in one of the umbilical creases. Your incision could either be transumbilical, it could be along the inferior crease, or it could even be along the superior crease of the umbilicus, but all these incisions would be camouflaged inside the umbilicus. So the cosmetic appearance is also good. Now we also talk about this baseball diamond concept of port placement. And there are three rules which you must remember when you're going to put and apply this concept. The first rule tells you that laparoscopic instruments should behave like a type 1 lever. I'll explain what that means in a minute. The second rule is that the telescope should be in the center or in between the two working instruments. And the third rule, which I have already explained earlier, that the manipulation angle between your working instruments should be 60 degrees. So what is this rule number 1? It is telling that laparoscopic instruments should behave like type 1 lever. Now, a little bit of simple physics. A lever system could either be a type 1, type 2, or a type 3 lever system. It depends upon the position of the fulcrum whether it is located in between the load and the force on the effort arm, or is it located on one side. So I'm just going to stick myself to type 1 lever. The best example of this type 1 lever would be a seesaw. And I am telling that laparoscopic instruments should also work like a lever. In fact, they are actually like a lever, because if you look at this image, half of the instrument is outside, and this is known as the force arm. Half of the instrument is inside the abdominal cavity. This is known as the load arm, just like any other lever. And lever has a fulcrum, and in our laparoscopic procedures, the port side where the cannula is going through the abdominal wall is your fulcrum. You are going to move your instrument around this fulcrum. And for the instrument to behave like type 1 lever, the fulcrum should be in the middle or in the center of the effort and the load arm. This is the best example of a type 1 lever. You see, this is a simple seesaw. One could be assumed to be the load arm, the other is the effort arm, and right in the middle you have this fulcrum. Same concept is applied in laparoscopy also. Why are we insisting on type 1 lever? Because if your laparoscopic instrument behaves like type 1 lever, which means in this case, half of the instrument would be inside, half would be outside the fulcrum. So when your instrument is going to be like a type 1 lever, then any force and movement outside which you're going to apply using your hand would be transmitted equally and in an opposite direction inside. So the movements in laparoscopy, if you realize, are counterintuitive. Unlike in open surgery, if you're holding a scissor and if you want to cut something on the right side, then you will move your hand towards right. It is the exact opposite of this in laparoscopic surgery. If you want to move the tip of the instrument which is inside towards right, the hand which is outside and holding the instrument has to move towards left side. So the movements in laparoscopy are counterintuitive, and because of that, we need the instrument to behave like a type 1 lever. So that if I'm moving the instrument outside by 10 degrees, it moves exactly by 10 degrees inside also. Otherwise, it will become very difficult for us to operate. So this is the concept of type 1 lever. As again I was explaining, the length of your instrument is going to be 36 centimeters. That means 18 centimeter of the instrument is inside, 18 is outside the abdominal wall. The fulcrum is going to be your abdominal wall port. So what does this mean? This means that for the laparoscopic instrument to behave like type 1 lever, your port position should be correct. And that port has to be at a distance of 18 centimeters from the target of your surgery. So automatically, when you put that instrument inside that port, the instrument tip would reach the target of surgery with only half the length of the instrument. That is again 18 centimeters. So this is the concept of or rule number 1 of our baseball diamond concept. Now, trying to put everything together, how are we going to put it into practice? So first of all, take the telescope inside, locate the target of your surgery. Now, every surgical procedure has a defined target. Target is identified as the area where you're going to do the most crucial step of the surgery. So for appendectomy, the most crucial step is ligating the base of the appendix. So the target would be the base of the appendix. In a lap chole, the target is the cystic pedicle, not the fundus of the gallbladder, not the Hartmann's, not the CVT. It is the cystic pedicle. For a splenectomy, the target of surgery would be the hilum of the spleen. For a TLH, the most important step is dealing with the uterine artery, so we consider it as the target of surgery. Go and identify the target of surgery with the telescope. Find out the length of the instruments. For adult patients, you would be using a 36 centimeter. Then draw an imaginary arc on the abdominal wall at 18 centimeters from the target and place your working ports on this arc. So this animation will help clarify what I am trying to convey here. See here, this is an example of a lap appendectomy being done. This is the target of my surgery. So my telescope is going to go through the umbilicus. I'm going to locate the target of surgery, draw this imaginary arc of 18. Now, when I take my telescope in, my instruments in, you will find that I have already attained the ideal working angles. So angle between this instrument and this instrument now would be 60 degree. The azimuth angle here would be 30 degree. Because I have placed this port at 18 centimeters, see this is the arc of 18. So because this port is at 18 centimeters, so only half the length of the instrument would be in, the rest half would be outside the abdominal wall. Instrument automatically starts behaving like a type 1 liver. And this port has to be 7.5 centimeters away from the telescope port on either side. And I mentioned earlier, if it is 7.5 centimeters, automatically this azimuth angle would become 30 degrees. So this is the concept, the science behind the port placement in laparoscopic surgery. So ideally, this is the rule number 2. It states that the telescope should be in between the two working instruments. And this is known as contralateral port position. Please do not confuse this contralateral. It has got nothing to do with the site or the side of the surgery. Contralateral here refers to a position in which you have a telescope and then the left and the right instrument are on the left and the right side of the telescope. This is what we mean by a contralateral port position. And why are we insisting on that? Because if the telescope is in between the two working ports, it will see both the instruments equally well. So it is more closer to our binocular visions. And we are insisting on that because this gives us better depth perception. Now, this brings me to another very, very important aspect of minimal access surgery. And we all know this, you must realize this, that there is lack of depth perception when you're going to operate laparoscopically. This brings us to the next principle of visualization. So minimal access surgery is also known as image guided surgery because you are actually going to see an image on the monitor and you are going to operate looking at that image. Hence, we call it image guided surgery. Most of the times you will see a system which is going to give you a 2D vision. Although 3D laparoscopic systems are available, they were introduced many, many years back, but they did not took off well. There are certain issues, the limitations of minimal of 3D laparoscopic systems, so they did not become very popular. So conventionally speaking, when you're doing minimal access surgery, you will be looking at a 2D image. This image on the monitor will not give you a depth perception. Now, this is drastically different from how we do open surgeries. In open surgeries, we are operating in a three-dimensional space and using our own stereoscopic binocular vision, we have depth perception. In laparoscopy, we are still operating in the same 3D space, three-dimensional space, the abdominal, the pelvic cavity. However, we are looking at an image on the monitor which is only two-dimensional. This confuses our brain. So with practice, you start understanding the depth. The surgeon needs to develop this cognitive depth perception. And how do you gain that? How do you start estimating the depths? By the use of depth cues. There are subtle signs which our brain recognizes, and we are familiar with those signs. So once I tell, they will immediately realize that yes, we are making use of these signs subconsciously also. So these are some of the important depth cues. If you're looking at two objects and one object is nearer to you, the other object is behind the first object, you will automatically know that the object which is behind, because it is blocked by the object in the front, that the object behind is at a further distance away than so the one which is completely seen is nearer to you, the one which is occluded is at a further distance. Relative size of the object, anything which is closer to you appears bigger. Anything which is far, far away from you will appear smaller. This is nothing but a depth cue. Look at the shadows. The shadow is always below. That means wherever the shadow is, that is going to be the lower part of the object. So so we are used to this, isn't it? We are always used to finding our shadows on the ground. Sun is up. So automatically we know, or our brain understands what is the correct orientation of that image. Not only these, there are multiple other depth cues. Contrast gradient. Anything which is closer to you, the objects which are closer to us, they appear to have better colors and contrast. The colors fade out as the object moves away and away from it as the distance increases. Excuse me. Texture gradient also improves. You can see more details of the object in the image which is closer to you. Similarly, as the object moves away from you, there is a linear parallax. There is convergence happening. Then there is motion parallax. Any object which is closer to us appears to move faster as compared to an object which is further away from you. You can all recollect from your train journeys or car journeys. The trees right next to your car appears to gush past your window, whereas the large hill appears to move slowly, or the buildings, they appear to move slowly. The buildings are farther away, the trees are closer to us. These are standard monocular depth cues which we must also understand in minimal access surgery. This is how we start appreciating the depth in a 2D image. Having said that, I mentioned that there are 3D systems which are also available. So here the surgeon can wear these special 3D goggles, and looking at this 3D endovision system, you start getting a depth perception. Not only this, nowadays in minimal access surgery, we are trying to improve the quality of the image in many, many different ways. And augmented reality is one of those methods by which you can actually superimpose the 3D reconstructed images of the scans live during the surgery over the organs. So this is especially important when you are going to operate upon liver tumors, especially the ones which are buried inside the liver lobes and cannot be appreciated from the surface. Then also there is this fluorescence guided surgery which has come up in a big way. We are going to use certain fluorescence dyes which are visible only with this near infrared wavelength. There are various modes. This is the standard mode of fluorescence guided surgery, and the dye is the indocyanine green. So wherever you are going to inject and the dye is going to be present, that area would be seen as green under near infrared light. You also have some other modes which the software generates. This is known as the black and white or the spy mode. So again, the contrast is more. You can see whatever is white is being outlined by the fluorescent dye, and whatever is black, that area is not highlighted by the fluorescence. This another way of looking. See how colorful the surgical images are now becoming. This is all software generated. It is basically telling us the intensity or the concentration of the fluorescence dye or the ICG. So this is using a thermal representation, just like a thermal photography. Wherever in thermal imaging, wherever the temperature is high, that area appears red. The areas with low temperature, they start appearing bluish. We are using the same concept here, but using it for fluorescence. So wherever the fluorescence is going to be high, that area appears red. Wherever the fluorescence is less, that area appears yellow, green, and then blue. This is the color segmented fragmentation mode, different modes of fluorescence guided surgery. Just to quickly show you how we are making use of all these modes. So fluorescence guided surgery can help you. This is the spy mode. It can help you assess the vascularity of the tissue. We are doing an anastomosis here, and I'm interested to know, does this area has good blood supply or not? This is where the fluorescence guided surgery comes into picture. So you can use different modes here. These are all available at your fingertips with the press of a button. This is the CSF mode, and you can see red indicates very good vascularity. Okay, so on table, you are assured that the anastomosis which you are going to do here has good blood supply and very, very less chances of a leak because of ischemia. So advanced imaging modes of visualization are also available. Moving on to the next important concept, which is optimal access. So if you scan through the literature, it is reported that 50% of the inadvertent laparoscopic injuries, they occur at the time of entry. When you are going to put your varus needle, there is a reported incidence of 0 to 0.5% for bowel wall injuries, or it could be a major vessel injuries. So safe access is the very important first step of laparoscopic surgery. So from where you are going to access into the abdominal cavity is again dependent upon lots of factors. There are basically two kinds of techniques: closed access techniques or open Hussen's technique. So in closed access, you can start by putting in a varus and then creating a pneumoperitoneum, and then you put your working cannulas or the ports. Or you can go with a direct trocar entry without pneumoperitoneum, which is shown to be slightly more riskier as compared to the varus, because here we are not going to create a pneumoperitoneum. There is a third method of direct entry, but here we are going to use optical trocars like the VZ port and a couple of others which are available. Open access technique, also known as the Hussen techniques, involves a direct incision and placing the port directly without the use of a varus needles. So the operating space in minimal access surgery is actually created by insufflating the cavity or the space with gas. CO2 is our preferred gas. But a laparoscopic surgeon must understand the physiological effects of creating a pneumoperitoneum. You are going to fill that space or abdominal cavity with gas. This is going to increase the intra-abdominal pressures. This will hamper the venous return. This can restrict the movements of the diaphragm. It can lead to hypercarbia, renal ischemia, increased stagnation, pooling of the blood in the peripheries, leading to DVT. So these are all physiological issues related to creation of a pneumoperitoneum. And without pneumoperitoneum, we cannot operate. So a surgeon must understand the recommended pressure and flow settings. These you can find out when you switch on the insufflator and you see the readings on that. So because of lack of time, I cannot go into the details, but briefly touching upon that, in an adult patient, when you're going to operate, the recommended pressure settings for intra-abdominal, intraperitoneal surgeries, the preset pressure should be somewhere between 12 to 15 millimeters of mercury. For extraperitoneal procedures, if you are planning to do a TAP or a TEP or a retroperitoneoscopy, then you need to have a higher preset pressure, and this could be in the range of 20 to 22 millimeters of mercury. The recommended flow rates of CO2 should be 1 to 3 liters only, while you are creating the pneumoperitoneum with the use of the varus needle. Once the pneumoperitoneum is created, you are going to take out the varus and introduce your working ports and now connect the CO2 tube to the one of the ports. And while you are operating, you must keep this flow at 8 to 10 liters per minute. Next important principle is tissue handling. Now, I mentioned earlier, there is a lack of tactile feedback in minimal access surgery. Unlike in open surgery, where you can directly hold and feel the tissue, here you are going to operate with the help of these long instruments. And instruments do not have nerve endings. So there is a lack of tactile feedback when you are doing laparoscopic surgery. So more emphasis is paid on visual clues. Look how much you are pressing the tissue. And if you are holding a tissue, how much blanching is happening. If you're trying a intracorporeal knot, in open surgery, you can always pull the two ends and you know that your knots are tight. How do you assess the tightness of the knot in doing intracorporeal suturing? You look at the constriction ring which is formed over the tissue which you are ligating. So these are important visual clues. Movements in laparoscopy are obviously going to be counterintuitive. This is something which you learn with practice and develop the skill of operating with this counterintuitive movements. So a very important aspect of doing surgeries is the use of energy devices. Your electrosurgical units, it could be a standard monopolar, bipolar. Nowadays, we have lots of advanced energy sources like ultrasonic scalpel or vessel sealers. These are very, very integral to doing minimal access surgery. However, please remember that energy, the electrical current which we are using for dissections is an assistant, it is an add-on, it is an adjunct, and not a substitute for surgical judgment. So be judicious in the use of these energy sources. Again, because of lack of time, I cannot go into the details. But until and unless a surgeon understands the safe use of these energy sources, you can have lots of complications. You can have distant site electrical burns or thermal injuries happening during laparoscopy. So remember to do a safe surgery. And a well-trained surgeon is a safe surgeon. So there is going to be a learning curve to acquire all these skills. So you need to be ambidextrous. You need to develop hand-to-hand and hand-to-eye coordination. And you must start appreciating the depth perception while you are operating upon a 2D screen. So you will require to train yourself, practice, practice, and practice. And you can practice on different modalities. We have wonderful endo trainers which are available. We have virtual reality simulators, which will give you almost like a real life like feel. And we have wet tissue or wet labs in certain center of excellences where you can go and get yourself trained. Patient safety is paramount. So when you are operating, first identify the anatomy before you cut or divide or ligate anything. Achieve good hemostasis and always maintain a low threshold of converting that minimal access surgery into open surgery. Please remember, minimal access surgery is not a religion, and to convert from it to open is not considered as a failure. Rather, it should be looked upon as a very strategic decision so as to avoid any complication and to do a safe surgery. Patient selection is equally important. There are lots of factors. Simply because you can do laparoscopic surgery for that disease does not mean that you have to do laparoscopic surgery. Make sure that the indications are correct for laparoscopic surgery and the patient is suitable for laparoscopic surgery. High BMI patients, complex diseases, lots of associated comorbidities are all going to increase the risk of laparoscopic surgeries. So please select your patients wisely. So in current times, laparoscopic surgery has diversified in many, many ways. So robotic surgery is a different way of doing minimal access surgery. We are doing single incision surgeries, or the correct name for those procedures is laparoendoscopic single site surgeries. We are also trying to do endoluminal surgeries, trying to do surgeries without giving a surface incision or a scar, truly scarless surgeries. And we are also experimenting with hybrid surgeries, which means we are going to do a procedure making use of both laparoscopy as well as GI endoscopy. So the future is really exciting. With the advent of AI in surgery, now we are doing AI guided surgery. It is going to improve, it is actually improving the safety profile and the outcomes of our procedures. We are making use of augmented realities in our procedures. And slowly, the way I see the future, we are heading towards flexible robotic surgeries. Again, going completely endoluminal and transluminal, because that would probably be the minimal access surgery in its truest form, to do a surgery without giving a skin incision. So that is where the flexible robotic surgical platforms are coming in. So just to summarize my talk, minimal access surgery is an entirely new philosophy. It's not just a simple technique. And as a laparoscopic surgeon, you must train yourself to grasp these principles so that you can do a safe surgery. The principles of treatment and surgery are always going to remain the same. Just because now we have laparoscopy doesn't mean that our indications or the steps of surgery are going to change. You as a surgeon are always the master, whether it is laparoscopic, whether it is robotic surgery, it is your mind which is going to control the machines and the tools which you are going to do. So remember that the technology which you are having at our disposal is only meant to serve the surgeon and the patients to improve the outcomes of the procedures which you are going to do. I'll stop here. Thank you very much for your patient hearing, and I'll be happy to take any questions.
Thank you so much, Professor Dr. Bhavneet Bhalla, for the insightful presentation. Now we are going to start our Q&A session. I will be reading the questions from the chat box. If you want to ask your question directly, please use the raise your hand option, and if time allows, we will invite you to speak. And remember that we only have 10 minutes for our Q&A session. I will be reading the questions, and Dr. Bhavneet Bhalla is going to address them one by one, and we will try to address as many questions as possible. Dr. Bhalla, the first question that we have here is from Hassan Momin. He's asking, considering the umbilical cord traverses a naturally weak area of the abdominal wall, how does its risk of incisional hernia compare to non-midline ports? And in your experience, how do you prevent it in real practice?
So, as I mentioned in my talk also, as laparoscopic surgeons, umbilicus is a very favored site. It's a favorite site for us. So we love to put our Veress needle and our optical ports through the umbilicus. And because there is umbilical scar there, you're not going to go separately through all the layers of the abdominal wall. Everything is fused, so the entry is easy, it is safe, and the principle of laparoscopy is also that any incision which is more than 10 mm or more than 10 mm, you are always going to close it. You are always going to do a facial closure for it. So if you follow these two principles, then the chances of having an incisional hernia are extremely low as compared to the non-midline or non-umbilical scars. This is one of the reasons why we prefer to go through the umbilicus. The chances of incisional hernia are much less. But you do have to remember, if your umbilical incision is more than 10 mm, then you also must do a facial closure for that incision. Otherwise, the chances of having a port side hernia are higher.
Thank you, Dr. Bhalla. The next question is from Mohammed Junaid. He's asking, what is the common complications of laparoscopic surgery which can become worsened and may be fatal?
So, unlike open surgeries, you have certain complications which are unique to laparoscopy. The first one is related to the creation of the pneumoperitoneum itself. If you distend the abdominal cavity too much, you can have lots of complications. Because of the restriction of movement of the diaphragm, the tidal volume starts coming down. Hypercarbia starts setting in. Renal ischemia can set in. Surgical emphysema can happen. DVT can happen. These are one set of complications related to minimal access surgery. The other could be with your access techniques. So whether you go with a closed access technique using a Veress or a port side, it is always going to be blind. One of the commonest complications of laparoscopic surgery is port site injuries. You are introducing the Veress, and if your technique is not correct, your Veress may enter into either bowel or bladder or blood vessel, and you have a complication at the very first step of the surgery. Then you are extensively going to use some sort of energy source to dissect. Besides using your cold dissection with a scissor, how do you coagulate? How do you achieve hemostasis? You will coagulate. You will use either a monopolar or a bipolar, or you may be using a ligashore. These are energy devices which, if not used properly, can themselves lead to a lot of complications. And because there is a lack of depth perception, if you are not a trained laparoscopic surgeon, you may cause more visceral injuries as compared to if you are doing open surgeries. So all these things are unique to laparoscopic surgery.
Thank you, Dr. Bhalla. The next question is from Twilde Ebroha. I hope I pronounced the name correctly. The question says, from your experience, what are the most common patient safety risks during minimally invasive surgery, and how can the pre-operative team prevent them?
So patient selection is very important aspect. You should not immediately jump on the surgical procedure. First, as I mentioned earlier, first see whether that patient is a good candidate for minimal access surgery. If the patient is unfit for minimal access surgery, don't do that minimal access surgery, rather convert to open or start as open. This is the first thing which you have to remember. Any patient who is elderly, who has lot of comorbidities, high BMI patients, cardiac patients, COPD patients, these patients will not tolerate the pneumoperitoneum which you are going to create as a first step. Isn't it? Any patient who is in borderline shock or is already in shock, either it could be septic shock or it could be hypovolemic shock, these patients also will not tolerate pneumoperitoneum. And that's the first step of the surgery. So all these patients are not candidates for minimal access surgery. Avoid doing this. Evaluate your patients properly. That's it. I hope that answers the question, or was there a part 2 of the question?
I think it did answer the question. We're going to move to the next one. The next one says, thank you, Professor, for the insightful presentation. My question to you, you mentioned that MAS is cost-effective, but LMIC out-of-pocket expenditure by patients is high. What is your suggestion on this? And how is TORG contributing to make MAS easily accessible in LMIC?
So upfront, you might think that minimal access surgery is costly, but it's partly true. If you look at the overall cost of the treatment, it is cost effective. I agree with you that there is going to be an initial capex. There is going to be a capital expenditure initially to procure all the equipments which you are needing to, isn't it? That's the initial cost. But if you look at the overall cost of the treatment, it comes down. The patient saves rather than spending more. The patient's stay in the hospital is going to be less. The analgesia requirement, the medicine requirement is going to be less. The recovery is faster. So the overall expenditure, even from the patient's point of view, is less. The patient recovers earlier, goes back to work earlier, isn't it? So if you look at the complete picture, it may appear that the cost of doing a laparoscopic surgery is higher than that open. The final cost comes out to be much less as compared to open surgery, where the patient would probably be staying much, much longer. The chances of complications are much more. So that way it makes sense.
Perfect. Thank you, Dr. Bhalla. The next question is from Mahmoud Baluch. He's asking, how can an assistant surgical staff contribute to the success of laparoscopic procedure? Please just give a brief overview.
A surgeon is as good as his team, his or her team. So the presentation which I have given here is not meant only for the young surgeons. This is a society of all the OT technicians, anesthetists, assistants, surgical assistants, as well as surgeons. And whatever I have been talking about over the last 30-40 minutes is not meant only for surgeons. Everybody in the team should understand what they're trying to do. This is a teamwork, and your understanding, whether you are an OT technician or a scrub nurse or anesthesia technician, if everybody is on the same page, the entire team knows what is being done, what should be done, how it should be done, what should not be done, what are the principles of ergonomics. You are going to complement each other, and the result of that team, that procedure is definitely going to be better. Somebody could be skipping on something, could be doing something wrong. So we all learn from each other. So I would say that whatever I have been talking about is not targeted only for surgeons. All OT staff should understand these concepts and contribute as a team to the procedure which is being done.
Thank you, Dr. Bhalla. Even though I see that we only have 2 minutes, I'm going to take another question and then we will end the Q&A session here. Yes, as we attempt to offer most of our patients with MAS, but sometimes there are moments we need to convert open surgery according to your experience, when is the right time to decide to convert to open surgery? Thank you.
That's a very important question. See, you find yourself in a situation which you know that you cannot now handle or manage via laparoscopy. It could be any situation. It could be a hemorrhage and you are unable to stop the bleeding. It could be difficult anatomy and you're not able to make sense of where is the organ which you are looking for. For a simple lab poly, you are unable to understand the anatomy because of a difficult or a frozen calyx. Rather than spending another 30, 40, 50 minutes without making any progress, you can now do more harm to the patient. So keep your egos aside. It is not a failure, as I mentioned in my talk. It is a very, very important decision. So the moment you find yourself in a situation which you cannot manage, now again, examples I told you, difficult anatomy, or you want to do now a procedure which you don't have the skills. Supposing a bowel perforation happened, inadvertent, you opened up the bowel, and you do not know, you don't have the skills to do a laparoscopic bowel repair. It automatically becomes an indication now to convert and do. Rather than risking and doing a risky procedure, trying to attempt to do it laparoscopically, I would never recommend that. So the moment you find yourself that now you cannot handle this situation laparoscopically, simply convert rather than wasting time and delaying that decision. This can further increase the possibility of more complications. So I think that in one line will tell you when to continue with lab or when to convert. I hope that answers the question, please.
Thank you,
Farad?
Dr. Bhalla. Thank you so much. Thank you for the insightful presentation and for answering the questions. We're now out of time, and we want to be respectful of everyone's time. We appreciate your participation, and the Q&A session is now concluded. We're now moving to the closing remarks by Dear Blessing.
Thank you so much, Professor. On behalf of the Operating Room Global, I would like to sincerely thank our speaker for his valuable insights and our participants for joining us from across different countries, time zones, and professional backgrounds. We recognize that many of you are participating despite busy clinical schedules, varying internet access, and language differences. We truly appreciate your commitment to learning and to improving surgical and preoperative care in your local setting. Please feel free to share key lessons from today's section with your teams, institutions, and professional network. Then, as part of strengthening safe and effective practice globally, we encourage you to stay connected with TORG through our upcoming webinars, training programs, and research activities, which are published on our website and across our official platform. To receive our TORG accredited training certificate, please note the following. First, immediately after this section, the evaluation and certification form will open in the browser on your device and remain active for 24 hours only. Secondary, certificates are issued within 5 to 7 working days after successful submission. Evaluation is mandatory for accreditation, and certificates are linked to your TORG membership ID. Once again, thank you for being part of the TORG global community. We wish you a safe, productive day or evening ahead, wherever you are joining us from. Thank you once again for joining us, and we look forward to supporting your continued professional development with the Operating Room Global. Thank you.
All right, everyone, thank you so much for participating. We do apologize for not being able to take all the questions, and we wish you a great day.